Hello, GPSA. My name is Patel. I'm representing the Kirk Kerkorian School of Medicine and the Lou Reveau Center for Brain Health at the Cleveland Clinic, and I will be presenting a case of severe sensitivity to a single dose of clozapine in a patient with Lewy body dementia. Here is a table of contents for you. Our introduction will be to Lewy body dementia and comparing and contrasting to other neuropathologies, as well as an introduction to clozapine, our offending agent. Then we'll move on to our patient presentation, some of the diagnostics and imaging and the medications that he was trialed on. Then we'll move on to our discussion. How has clozapine been used in other dementias before? The basis for clozapine use in Lewy body dementia. Some of the utility for clozapine in this case, how clozapine may have contributed to this patient's demise, and some key provider takeaways when discussing clozapine use and also with Lewy body dementia patients. So let's move on to the introduction of the physiology of Lewy body dementia. So Lewy body dementia is a neurodegenerative disorder associated with the accumulation of aggregates of Lewy bodies. And these Lewy bodies are dispersed throughout the brain, and particularly where they lie is associated with the symptomatology of Lewy body dementia. Now, how is Lewy body dementia associated with other neuropathologies? Well, it's closely related to Parkinson's disease. As I mentioned, they are both alpha-synucleinopathies, and many studies report that Lewy body disease, or DLB, and Alzheimer's disease often coexist in the same patients. So these diseases can often be intertwined. And the clinical phenotype of LBD, and this is important to keep in mind as we discuss our patient, is marked by striking and vivid hallucinations, hypersomnolence, spontaneous Parkinsonism, and a REM sleep behavior disorder. So let's introduce clozapine. Clozapine is an atypical antipsychotic, and prescribing clozapine often follows the therapeutic metaphor. In Lewy body dementia patients, we often don't know what their best medication will be. However, they often best respond to antipsychotics. We treat their symptoms, therefore following the therapeutic metaphor. However, antipsychotic use in Lewy body dementia patients may be dangerous because they are extremely dopamine sensitive. Clozapine, on the other hand, is unique because it is demonstrated to be effective in treating treatment-resistant schizophrenia, which is also an extremely dopamine-sensitive condition. Clozapine, however, has been avoided by healthcare providers because of an unusual side effect profile, including agranulocytosis, seizures, and cardiomyopathy. However, there are many studies that demonstrate that clozapine has a preferable pharmacologic profile and a low potency for dopamine blockade. And this at least would provide us a theoretical framework for using clozapine in treating treatment-resistant Lewy body dementia. So there is some promise there. Now, who is our case, or who is our patient? Well, this is a 68-year-old white male who had a year history of worsening cognition and visual hallucinations and a REM sleep disorder over the 5 years. So now we're building the idea that he may have Lewy body dementia. Now, over the next 2 years, he declined in his cognition, he worsened in his neuropsychiatric symptoms, and his visual hallucinations worsened to become persistent and threatening. Now, on diagnostics and imaging, his PET scan had a very typical sign called the cingulate island sign that we associate to be very specific of probable Lewy body disease. Further, several follow-up medical investigations such as urinalysis, chest x-rays, brain scans, all failed to reveal any potential contributors to his decline. When taken in isolation of these other factors, Lewy body dementia becomes the most probable diagnosis. And here's what we mean by the cingulate island sign. This is the PET scans of our patient, both the axial view and the sagittal view. It is important to know what the cingulate island sign is. It's just that, this is kind of a visual indication of what was going on in the patient's brain at that time. The patient was trialed on multiple medications as well. Initially, his visual hallucinations responded robustly to galantamine, but when his hallucinations reemerged, they reemerged with quite a vigor. His trials of quetiapine, another atypical antipsychotic, rivastigmine, pimavanserin, and olanzapine all failed. And he was started on escitalopram for an increasing agitation. Further, for his worsening sleep disorder, he required benzodiazepines for sleep. So you can see he's very dependent on multiple medications. And this is a timeline for your, just to keep everything in check, for your perusal regarding the medications that he was trialed on. Now, Clozapine Administration. So at the very end of the line, he was treatment refractory to multiple medications. We decided to pursue treatment with Clozapine. We started him at a very subtherapeutic dose of 12.5 milligrams and gradually titrate up based on the symptoms, keeping those side effects in mind. Now, the other antipsychotics could not be abruptly stopped. He was also remained on escitalopram for his agitation. And most importantly, his olanzapine was tapered from 20 milligrams to 5 milligrams over the course of a month, to be discontinued when clozapine reached 25 milligrams. Now, several hours after his first dose of clozapine, he worsened precipitously, became confused, and he fell. When he arrived to the ER, similar story. No other additional testing revealed any potential contributors. He became delirious and then minimally responsive, was discharged to hospice, died peacefully 7 days after, and perceivably due to that initial dose of clozapine. There were no other offending agents that we could pinpoint. So where does that leave us? Well, clozapine use in dementias could be a contested topic. Although it has a great specificity for the limbic system, and it seems to be more preferable than other antipsychotics due to the low incidences of extrapyramidal symptoms, it did result in this patient's demise. Clozapine is the gold standard therapy for treatment-refractory schizophrenia, and has been shown to have potential for benefit when expanding to other disease populations. Now, unfortunately, for Lewy body patients, one of the hallmarks of their disease category is medication hypersensitivity. And unfortunately, these incidences of hypersensitivity have only been tenuously described in weakly evidenced literature. And predicting or anticipating an adverse reaction for healthcare professionals is difficult without stronger evidence to anticipate for. Now, clozapine use in Lewy body dementia it has some basis. Parkinson's disease is a successful avenue for clozapine use, and again, they have the same physiology basis. And a growing body of literature suggests that the best documented drug for visual hallucinations across the board is clozapine. So there is still basis there. And again, we've recreated this table to show you that clozapine use in patients with LBD has been shown to be good and also to be bad. However, again, these are case reports. They're not completely equivocal with what their findings are. The evidence is scattered. And what's important to note is that of the body of literature that is around, none of these patients so precipitously died following their clozapine administration as our patient did. Despite all this, we do believe that the decision to initiate clozapine is consistent with other literature that is out there, and he was absolutely treatment refractory. He failed multiple trials of multiple medications. We only chose to turn to clozapine as a last resort, really. Now, what could have contributed to his demise along with the clozapine? Well, for one, anticholinergic activity has been proposed for Lewy body dementia, and a loss of cholinergic action manifests in delirium and autonomic failure. Further, he was on multiple medications, and medications often have anticholinergic side effects. Further, the age-related breakdown of the blood-brain barrier can lead to medication and neurotoxicity accumulating in the brain. And these three effects, taken in combination with one another, could provide some basis for his demise. Now, what are some takeaways for using clozapine for providers? Well, you should take utmost care when utilizing clozapine. The REMS is a database for tracking patients with clozapine, and we encourage the use of that. And better monitoring. Assess patients for anticholinergic burden. Prescribe much lower initial doses with better titration. More frequently assess them for their anticholinergic burden. It really is on the provider to have better follow-up. So what do we conclude from this study? Well, As we said before, it's been efficacious in other trials. However, there's still little to be known about its use in Lewy body dementia patients. And it really is on the healthcare provider to take great care when using clozapine, even though it is a potentially promising medication.